Poor insight is the biggest problem that we have in my mind and in my experience. And if you look at the research, half of all our patients don't understand they're ill, and that lack of awareness goes on for years and even decades. And if you don't understand you're ill, big surprise, you don't want to take medicine for an illness you don't have. You don't want to go to a treatment center. You don't want to accept a therapist, a manager. It creates tremendous obstacles to being engaged in treatment, being involved in your own recovery. I used to think this problem was denial for many years. That's how I was trained. That's sort of the common sense reaction. But I used to argue with my brother. My brother had schizophrenia, and I used to say, you know, you're being stubborn, you're being immature, you're in denial. And it's really, now that I know the research, now that we've done research in the decades since I had those discussions, I'm the one who was in denial. I mean, it would be like saying to my brother or to my patients, stop hallucinating. What's wrong with you? You know, you're being immature. This is another symptom of the illness, like a hallucination, like a delusion, this lack of awareness. What I have learned and what the field has learned over the last 20 years is that what we're dealing with is another symptom of the illness, and the name of the symptom is anosognosia. This is a symptom that was recognized nearly 100 years ago in neurological patients who would have neurological deficits, for example, paralysis, and were unaware that they were paralyzed. You couldn't even teach them. I've evaluated patients like this. I can't even teach this man, he's paralyzed. And research on the brain in schizophrenia finds that deficits in frontal lobe functioning and even gray matter predict who has insight and who doesn't. It's a symptom of the illness, it's not a coping strategy. The scientific consensus that this is anosognosia and not denial has been in the DSM for 11 years now. And I'm not surprised that so few people in the audience were even familiar with the term anosognosia, even though it's in the DSM, even though it's in the research literature. And the reason is people get trained 20 years ago, and they're busy in their practice, and they're not reading all the research. And there's another reason. There was such a rush to judgment in our field, and it grew out of psychoanalysis, that what we are seeing when someone says, I'm not sick, is resistance, is denial. That just sort of makes sense, doesn't it? That this is a stigmatizing illness, and that's why the person says, I'm not sick. But then how do you explain when they're not even aware, when they have tardive dyskinesia, that they have a movement disorder, or the fact that it's cognitive function, it's brain dysfunction that is actually correlated with lack of insight or unawareness. Not things like how much stigma the person feels, not things like how defensive the person is. That research has been done. The story is an old story. The way we deal with it, now that we know what the real problem is the way we deal with all sorts of symptoms of the brain disorder, which is to look beneath the symptoms at the human being. What does this person want? Well, they want to be understood, they want to be respected, they want housing, they want relationships, they want work, and we look for those things that we can agree on with the person. So let's not argue about whether you're sick or not. See, now that I know it's a symptom, I'm not in denial, and I can put that aside. That's no longer a reasonable goal for me to have as a doctor, to try to convince someone who knows they're not sick that they're sick. That's unreasonable. Instead, I need to focus on, what do I want for this person? I want this person in treatment. I want this person to develop social skills, maybe work skills, and live a fuller life. And the goal is to, have what I want for this person facilitate what the person wants for him or herself. So the patient who tells me this is a mistake and I'm not mentally ill, I say, so let me see if I understand you. You don't belong here. You're not mentally ill. This has been a terrible mistake. I listen reflectively and actively. I don't contradict them. I don't correct them. I don't even rush to empathize with them. And what happens when I say to someone, so you're not sick and you don't need to be here, is they might ask me, well, can you help to get me out of here? And that's a problem you can deal with, because what you're doing first and foremost is respecting that person's experience. The whole philosophy of LEAP is that you win on the strength of your relationship. You don't win on the strength of your argument. So you don't argue that the person is sick. You don't even argue that the person needs to take medicine, even though you believe they would benefit from it. You gently give them your opinion when you use LEAP. It's a very humble way of giving your professional opinion. Well, since you've asked me many times now, I'll tell you, and I'm sorry I could be wrong. And I hope we don't have to argue about this, but I think the medicine will help you with staying out of the hospital. It'll help you not talk to the voices when you're at work so you can keep your job, etc. I focus on what the person wants. That's what LEAP is about. It's about developing a relationship that's strong, where the person feels respected and they trust me and they are interested. Now they're interested, in my opinion. The most common thing I hear is, I don't have time for this, and it turns out when you look at the research and when you look at our experience, it doesn't take any more time to use the listen, empathize, agree, and partner approach, the LEAP approach. It doesn't take any more time. The other common thing I hear is, if I listen reflectively, if I say to somebody, so you're not sick and you don't need medicine, is that correct? People worry they're going to make the denial worse. Well, remember, it's not denial. You're not going to make it worse. And they also worry that the person's going to ask them, well, will you help me with the CIA conspiracy? I'm going to talk with the Minister of Health about this. Will you write a letter for me? They're afraid to be asked to do things they can't do. And LEAP teaches you very specific communication strategies or tools to deal with those difficult questions. It's a common concern people have when they're learning LEAP, that I'm being dishonest. If I say to a patient, so let me see if I understand, your problem is that the aliens are broadcasting voices into your head, is that correct? They think that it's dishonest. Well, I don't believe the aliens are broadcasting voices. That's not what I said. I'm reflecting back what the patient has said to me. And when the person asks me, well, what do you think? They sometimes feel a little bit betrayed, and you have to just be careful not to overdo it. So rather than give your opinion, you can ask, can I give you my opinion? Because it sounds like we might have a misunderstanding. And then when you give it with humility. I could be wrong. And I'm sorry I have this opinion. I often also advise doctors to apologize. I'm sorry, I wish I didn't have this opinion, because I know it's going to upset you. It is not the patient's problem that I don't believe that the aliens are broadcasting voices. It is not the patient's problem. It's my problem if I want to help this person. I have to join them where they're at. Never being dishonest, never pretending I believe the things I don't believe, but demonstrating respect. And what's interesting is when I demonstrate respect for a person's point of view that they're not sick, they don't need medicine, and whatever the delusion is they might have, they are more inclined to demonstrate respect for my opinion. I think you should try the medicine for a month. My brother's experience and the patients I've worked with who have this unawareness are the loneliest people I've ever met. Because it's not just that doctors, police officers, people they work for, if they've lost jobs because of their illness, all are telling them, you're sick and you need medicine, and they know that they don't. It's not just that, it's their loved ones. That's the people closest to them are also, from their perspective, against them. The people, my brother, I was probably the person he was closest to on the planet. And for many years, I was his worst enemy, because I was joining in with all those people that were telling him, you're not who you think you are. You're actually a mental patient and need to be on medicine for the rest of your life. So it's a terribly lonely place, but we don't have to leave people alone and out of treatment. We can reach out to them where they're at, starting with their experience, not our opinion.